Welcome to Zcast, an informative Zotec Partners podcast that meets you where you are.
Good afternoon, everybody. I'm Tara Rowland, Zotec's Vice President of Sales Enablement. I want to thank each of you for joining us today for a deep dive into coding for interventional radiology. We are very lucky to have two credentialed coding experts on today's webinar. Joining us and presenting today is Stacy Hall. She's Zotec's Senior Director of Corporate Coding, and then Leslie Bargfried as well, our Corporate Coding Manager of Interventional Radiology. Both of these ladies are experts at IR coding and have been doing this for over 2 decades. So with that said, Stacy, I will turn it over to you.
Thank you so much, Tara. As Tara stated, my name is Stacy Hall. I am the Senior Director of Zotec's Corporate Coding Department. And before we get into the topics, I just want to give a little bit about what we do. The Corporate Coding Department is responsible for Zotec's Coding Quality Assurance Program, providing coding education for our employees, and documentation education for our providers. We stay on top of the latest reimbursement trends, some of which we'll be discussing today. We research the latest technologies and procedures performed by our clients, and we provide guidance from industry organizations such as the SIR, and we also work alongside industry experts. And this is important because a lot of times there's no current guidance on a topic. So we'll provide best practice coding and documentation recommendations when there's just nothing published with authoritative guidance or industry guidance from the SIR or the ACR or the AMA. So we're kind of like Zotec's own internal consulting firm that can help our clients with their coding and documentation questions. So having said that, today Leslie and I will be discussing 5 topics that are affecting interventional radiology from a reimbursement or an audit risk perspective. The first topic is in reference to prepayment audits that are being performed by UnitedHealthcare. Now, it's likely other payers are performing these types of audits to some degree, but the volume for UHC was at a level that we requested a meeting with the UnitedHealthcare auditing team to discuss their rationale for these reviews and to determine how we could decrease the number of charts that were being requested. As you can imagine, this process severely delays the reimbursement for these cases. So during that discussion, we learned a few things. UnitedHealthcare is performing prepayment reviews based on an internal algorithm that was created by Optum. It sounded super complicated, but the bottom line is that the more issues detected, the more reviews requested for those codes. For interventional radiology, there were 2 main areas we've seen requested with significant volume: ultrasound guidance for vascular access and moderate sedation. Now, for both of these items, the documentation is sometimes found in the patient's medical record outside of the dictated report. And it's actually acceptable from a compliance perspective for that to be documented outside of the dictated report. But UHC and other payers really must see the documentation in the report for proper reimbursement for the service. And for UHC, they have to see that to stop performing these prepayment reviews. So what's required from a coding guidance or a compliance perspective and what's required from a payer perspective are not always aligned. So it's best practice to always include this information in your dictation. So let's first discuss ultrasound guidance for vascular access and review the documentation requirements. According to CPT, documentation must include ultrasound evaluation of potential access sites, documentation of selected vessel patency, real-time ultrasound visualization of vascular needle entry, and permanent recording and reporting. The 2 elements that we most commonly see missing are documentation of selected vessel patency and the permanent recording and reporting. Regarding documentation of the recording, in 2012, Clinical Examples in Radiology clarified that this code does require permanent recording, but the radiologist is not required to document that the permanent images are stored, but that they must be retrievable in the event of an audit. But for United Healthcare, they are requiring to see the proof of permanent recording before they will reimburse for this code. If it is not documented in the report, proof can be separately submitted to them post-audit and they'll reimburse for the study. But this process has two issues. One, it continues to delay the reimbursement for the procedure. And two, the lack of documentation in the report will continue to trigger further chart requests prior to payment, which is going to continue to delay reimbursement for all of your studies that have ultrasound guidance for vascular access. Now, in order to avoid this issue, it's recommended that all 4 elements be documented in the dictated report. Here are a couple of documentation examples that include all 4 elements and should pass an audit for this service. So these support the evaluation, the patency, the access, and the permanent recording. Just a couple of different examples there. Now, moving on to the documentation requirements for moderate sedation. According to CPT, documentation must include an independent trained observer to assist in monitoring, documentation specifying the level of consciousness achieved by the patient as moderate or as conscious. And the reason for this is that the moderate sedation codes cannot be used for minimal or for deep sedation or for MAC. Specifically documenting the sedation as moderate or conscious will clarify the sedation codes are appropriate. Now also, if you're performing the procedure in a global setting, the specific drugs provided should also be documented because they're separately billable in that setting. Sedation is reported based on intra-service or face-to-face time. Intra-service time is defined as from the time sedation is administered until the physician leaves the patient. Documentation must support that the physician was present for the duration of the sedation time. Now, using the phrase intra-service or face-to-face will meet that guideline. Because sedation is reported based on time, the specific amount of intra-service time must be documented. A couple of rules about time. First, time is reported in increments of 15 minutes, and under 10 minutes is not reported at all. So it's very important that the amount of time is provided. Now, while documentation of these elements can be found in the facility's sedation record, again, UHC is expecting to see this documentation for reimbursement. So just like with the ultrasound guidance, the sedation record could be submitted afterward. But as we discussed before, this severely delays reimbursement of this service. And the lack of documentation in the dictated report will continue to trigger these audits prepayment. And another item to keep in mind, it doesn't just delay the reimbursement for the code that triggered the audit, but it delays it for the entire claim. Here are a couple of documentation examples that include all elements required for moderate sedation, including the drugs, if it's in a global setting, documentation that the sedation is moderate, the presence of an independent trained observer, and the amount of intra-service time. So it's important to note here that the amount of time isn't just documented, but it's specified as intra-service. Stating that time as face-to-face would also work as well. For the next topic, we will discuss Medicare's coverage policy for vertebral augmentation. Now, it would be great if there were a national coverage policy for this procedure, but unfortunately, each Medicare contractor has a local coverage determination. Each LCD limits the medical necessity for payment of these procedures and includes the indications for coverage, the contraindication, and a list of medically necessary diagnoses. Now, all Medicare contractors have either updated or are in the process of updating their local policies for this procedure. While many of the MACs are using the same format change, some do vary, and all of them vary as to the effective date of the new policy. Now, I've included quite a few slides that are to follow here to review these changes by MAC so that the appropriate information can be provided based on what state or states each practice locates in. So let's go through a quick summary of the changes that have been made overall to these policies. Then we'll drill down to the detail of each one. Now, most Medicare contractors will only reimburse for osteoporotic compression fractures. A couple of the MACs are also reimbursing for neoplastic compression fractures, but no other types of fractures are going to be covered, with the exception of Palmetto for one of the MACs. The MACs that only cover osteoporotic fractures state the following in their policy. They have a statement that says, coverage will remain available for medically necessary procedures for other conditions not included in this policy. So it'll be really necessary to monitor claims closely to see how each MAC is processing procedures performed for other conditions. For example, we found that even though they have that statement in their policy, most are not reimbursing for any other type of fracture except for osteoporotic. So the last bullet here, most of these new policies are requiring a multidisciplinary team consensus. Some of the policies specifically detail what that means. They are requiring all of the following to be involved with this: the decision to perform this procedure, or the referring physician, the treating physician, a radiologist, and a neurologist. Now, when this concept was first introduced late last year, the SIR listserv blew up with providers upset over this change. Letters were sent to the first Medicare contractors that implemented this requirement back late last year, requesting its removal by providers. They were doing this across the country. But all of the MACs that implemented that requirement as of this date are still standing behind it. There has also been no guidance on how this must be documented in the patient's medical record. Now, it does not have to be documented in the dictated report per se, but somewhere in the patient's medical record, whether it be at the facility or by the referring physician, should document this multidisciplinary requirement. Now, this slide contains a quick look of what each Medicare contractor is requiring for reimbursement, as well as the effective date for each. For the first 5 on the list, the policies all state that they will only cover osteoporotic fractures. They all require a multidisciplinary team consensus, and the specific team has been defined, as we just mentioned before in the last slide, to include the referring physician, the rendering physician, a radiologist, and a neurologist. So basically those first 5 MACs listed there, they really all have the exact same policy in place. Also, these first 5 MACs are the ones that have the statement that they will cover other medically necessary procedures for conditions that aren't included in this policy. For those MACs, these first 5 on the list, we have only seen NGS reimbursed for something else other than an osteoporotic fracture, and that was for a neoplastic fracture. Now, for the next 2, First Coast and Novitas, they're covering, per their policy, both osteoporotic and neoplastic fractures. And they do not contain a statement at all about a multidisciplinary consensus for those 2 MACs. And also note here that their policies have not yet gone into effect. The effective date for those is scheduled for July 12th. Now, Palmetto is the lone horse here. Their updated policy is still currently in proposed status, and an effective date has not yet been determined. But their updated policy is very similar to their current policy, and it still includes vertebral fractures due to various conditions, in addition to osteoporotic and neoplastic fractures. Now, they do mention a multidisciplinary consensus, but they don't define what that team must include like those first 5 do on this list. Now, for all of the following slides, I've created a chart by Medicare contractor that provides a summary of the changes. I wanted you guys to be able to, if whatever state you're in, for you to be able to just see one snapshot of what the requirements are. So that's what I put together here. The left side of the chart is it provides the details of the old policy that was in place before, and the details on the right side of the chart are the new updated policy. Now, I've included links to the local coverage determinations themselves at the top of the page, as well as their associated coding articles so that you can easily get to that information. I've also included a link to each MAC's reconsideration or comment process right here. So that'll take you directly to the page on their website where you can figure out how to contact them in case anyone would like to have a conversation with the MAC directly about these changes. Now, the items included in this chart detail the diagnoses that are covered for each. It also details the exact verbiage regarding the multidisciplinary team directly from each policy. Now, I've also included the states that are covered by each MAC. So this first slide here is for CGS, and that covers Kentucky and Ohio. Now, the next 4 slides, as we saw in the slide before, the first 5 on the list are the same type of policy. So these next 4 slides are the same as CGS, but they have the links that are specific to each one of those MACs. So this is NGS, this is WPS, this is Noridian's JE jurisdiction, which includes California, Hawaii, and Nevada. And then this is the rest of Noridian's jurisdiction, the rest of the states that are covered under Noridian, the JF jurisdiction. Now, the next 2 slides are for First Coast and Novitas, and they both have the same policy guidelines. So this one is for First Coast, and this one is for Novitas. And just to detail this coverage requirement section down here at the bottom, the proposed policy for these 2 MACs did mention a multidisciplinary requirement, but when they published the final policy that's going to be effective in July, they replaced that requirement with a continuum of care section. Now, this specifically states that all patients presenting with vertebral compression fracture should be referred for evaluation of bone mineral density and osteoporosis education for subsequent treatment as indicated, and instructed to take part in an osteoporosis prevention or treatment program. So once again, that should be documented in the patient's medical record someplace that took effect. So whether, again, it's in a referring physician's medical record or in the facility's medical record, there will need to be something somewhere that talks about that in the event of an audit. Again, these policies for First Coast and Novitas do not go into effect until July 12th. Then finally, Palmetto's policy, which is the least strict of all and includes a much more extensive list of Medicare, medically necessary diagnosis codes. And here's the link up here, and you can review that link to the proposed policy, and it will give the full list of diagnosis codes that are covered. Now, I'll turn it over to Leslie to review the rest of the topics.
Great. Well, thank you, Stacy, and good afternoon, everyone. Thanks to all those that are taking your time to join us today. My name is Leslie Barfried. I'm the Corporate Coding Manager for Interventional Radiology here at Zotec. One of my primary roles is physician education and work daily with many groups and doctors regarding a lot of these challenges and documentation issues to assist in completion and effective documentation for their procedures, capturing all the revenue possible. The next topic we're going to cover here is Y90, selective internal radiation therapy, or CIRT, and some of the challenges that I specifically and doctors have experienced regarding documentation and billing. So this revolves around a couple of elements for the procedure that may be challenging for physicians to report. So as many of you know, Y90 is a multi-stage procedure, which can be very complex, not only from a clinical perspective, but also from a coding and reimbursement perspective. Today, I'd like to discuss a couple of those elements that have posed challenges for many groups I have worked with. These elements are regarding documentation and capturing charges for therapeutic radiology treatment planning and basic radiation dosimetry calculation. These are 2 elements that I see many times physicians leaving on the table. So both of these elements are performed as part of the course of treatment and may be separately billable when performed by an authorized user and appropriately documented. These elements are a required component of the therapy and will take place at some point throughout that treatment plan. So first, we'll step back, a little bit of background on the progression leading up to the decision to proceed with these Y90 treatments, and determining if the patient is a candidate. The patient will undergo the procedural phase, pre-procedural phase of the case. This will include an initial evaluation, the pre-procedural mapping angiography, which is performed to assess the tumor volume and vascularity, map the blood supply to the liver, evaluate any arterial portal shunting, variant anatomy, and potential non-target vascular beds. The mapping study will typically include 3D angiographic images for post-processing. During this study, TC99 MAA, or macro aggregated albumin, will be injected to simulate the radiation exposure that may potentially occur during the Y90 administration outside of the target treatment zone. In some instances, pre-treatment embolization may also be required to prevent that Y90 exposure to any non-target vascular beds during the treatment. For example, embolization of the gastroduodenal or the gastric artery may be performed during that mapping study. The patient will then be sent to nuclear med for hepatopulmonary shunt study to determine if the patient is a candidate for therapy, or if and how much the dose may need to be adjusted. Based on all of this information, if the patient is then deemed a candidate, the treatment plan and dose calculations will be formulated. Now, depending on the workflow and licensure in your practice or facility, there are two different scenarios that may take place regarding which physician performs the treatment plan and dose calculations. The interventional radiologist may be an authorized user, or may be working in tandem with an authorized user outside of the group practice, for example, a radiation oncologist. So let's talk briefly about the role of an authorized user. What is an authorized user? Well, an authorized user is the physician that has completed all requirements of training according to the Nuclear Regulatory Commission, the NRC licensing guidelines. This physician meets the training and experience requirements, has met 80 hours of classroom and lab training, including Y90, has work experience under the supervision of an authorized user or a manufacturer rep for Y90, and many other requirements. The authorized user must also be listed on the facility National Regulatory Commission, the NRC license. So is your IR an AU? If the interventional radiologist is not an AU, the treatment plan and dosimetry calculations will require dual physician involvement, and the AU, authorized user, if that might be a radiation oncologist, would be responsible to perform the treatment plan and dosimetry calculations. However, more commonly and most often, I work with groups where the interventional radiologist is the authorized user. And in that case, the entire course of treatment may be performed and reported by the IR physician alone. Now, specifically, those elements of dosimetry calculation and treatment planning. So in my experience with groups, the most difficult aspect of this is documenting and capturing these elements. This poses challenges for several groups. For reasons, it's just a workflow process and needs to be worked through. Hospitals may have ordering or system limitations that do not allow a requisition to be created. Depending on the timing and the performance of those procedures, the patient is not registered at the facility on that specific date. Some physicians may document this information in the medical record, handwritten or otherwise, but then the information never goes any further. And then I've worked with some physicians who don't even realize that these elements may be billed in addition to the mapping and delivery procedures. So it's important that you work closely with your facility and billers to ensure you're capturing all the reimbursement for these very involved and complex cases. So I have worked with many physicians and facilities to assist in developing a workflow to capture this for reimbursement. So let's discuss what's required for these procedures and then look at an example documentation. The pre-procedural preparation and planning phase consists of considerable work prior to the delivery of the radiotherapy. Institutions licensed to administer these agents must have a licensed authorized user, whether it's the interventional radiologist or the rad-onc department. This physician is responsible for the pre-procedural preparation and work and the delivery of the radiotherapy. Complex therapeutic radiology treatment planning may be reported when the authorized user utilizes the following data in the planning for dose and timing of treatment. This would include prior CT scans, angiographic studies, cross-sectional imaging, previous treatment, the TCMAA scan, as well as 3D post-processed images to plan the treatment of the Y90. Documentation must include how each of these studies was used in the planning. Now, documentation, the dictated report can be performed on the same day as the mapping study or on a separate day after all the imaging is obtained and reviewed. If performed on the same day as the mapping study, the treatment plan can be dictated on that same report, but it's recommended to document a separate section, a whole separate paragraph, header with a paragraph to include the treatment plan information. If performed on a separate day, this can be challenging. A separate requisition may be required from the hospital. That is where the workflow process comes in, and the facility may have to be involved. So an example for the therapeutic radiology treatment planning would include the prior history reviewed, and the radiation treatment therapy with microspheres was deemed most appropriate. Y90 dose was calculated by the authorized user using the liver volume with adjustments, performance status, liver function tests, all of these elements of what was used to come up with that treatment plan, physical exam, and the desired dose to be delivered to the tumor. Given the dose, it was obtained from that calculation, and it will be administered to the right lobe of the liver, intra-arterial, and will be verified using a post-delivery Bremstra lung nuke med imaging scan. Now, for our basic radiation dosimetry calculation, once a treatment plan has been formulated, the dosimetry calculations can then take place. This may require adjustment or to be repeated throughout the course of therapy, depending on the clinical scenario of the patient. If the patient has multiple tumors and will be brought back for additional treatment, adjustment to the dosimetry may be necessary. The AU is also authorized user responsible for the safe handling, receipt, accounting, and storage of that Y90 dose. Per the NRC regulations, a record of the Y90 dose in the facility or office must be documented. Now that can remain in the chart. That is not required for any billing purposes. The dosimetry calculation, again, can be dictated on the same day as either the mapping study or the Y90 if performed. Again, if it's documented on the same day, it can be dictated on the same report, but a separate header or paragraph should be documented to include this information. If performed on a separate day, again, it might be a little more challenging to acquire a requisition for capturing, being able to dictate and capture those elements. So we can take a look at an example documentation for that. We have our dosimetry calculations performed based on body surface area, tumor volume, patopulmonary shunt, and prior therapeutic interventions. The available imaging studies were reviewed, measurements of the lobes, the tumor volume, the shunt study with a fraction of 16.5. So the total assayed dose for the right hepatic lobe is given, And Y90 throughout the middle hepatic artery was performed, and 92% of the assayed dose was administered throughout the right hepatic artery. On to our next topic, we'll cover a current bundling edit for sclerotherapy when performed with endovenous laser ablation. So back in October of last year, 2019, the National Correct Coding Initiative created a bundling edit for sclerotherapy when performed with EVLT, endovenous laser ablation. The National Correct Coding Initiative, or NCCI, is created and maintained by CMS. This identifies code pairs that may be considered to be inclusive to one another or to be a component of a more extensive procedure. This is not only followed by Medicare and CMS, governmental payers, but also many commercial or private payers follow these NCCI bundling guidelines. So when sclerotherapy is performed, this edit essentially states when it's performed on the same veins or anatomic region during the same encounter as EVLT or laser ablation, the sclerotherapy is bundled into that EVLT, the more extensive procedure, and cannot be separately reported. An example of being performed at the same encounter would be when sclerotherapy is performed during the same session via the same access to achieve complete venous closure that cannot be achieved by the laser ablation alone. So when sclerotherapy is performed on different veins or anatomic regions during the same encounter, the sclerotherapy may be unbundled by reporting this with a modifier 59 if it's medically necessary and supported by the documentation. For example, EVLT is often performed in the GSV, the greater saphenous vein. If sclerotherapy is medically necessary and performed during the same session on a tributary or perforating vein, for example, the posterior tibial perforating vein via separate access, this may support unbundling. So again, it's important, if medically necessary, that the documentation support the medical necessity for a separate and distinct procedure, that the veins are in separate anatomical areas, treatments are performed by a separate puncture sites, and the name of the tributary or perforating vein treated using the sclerotherapy. So we do have a documentation example for this. Under ultrasound guidance, the needle was used to access the right greater saphenous vein within the right thigh. Wire was advanced, exchange was made for another wire, and a 5 French 45 centimeter sheath was advanced into the femoral vein. Laser fiber was positioned approximately 3 centimeters from the saphenofemoral junction. Tumescent anesthesia was then administered. Under ultrasound, the laser was activated in continuous mode with 7 watts. Total of 1,052 joules was administered as the laser was pulled back. Total treatment length was 23 centimeters. Subsequently, attention was then turned to the right calf with a needle puncture of an insufficient anterior and posterior tibial perforating veins. Polydocanol was administered and sclerotherapy of those perforator veins was performed. Now, our last topic for today, we will cover a recently implemented Medicare review for the RAC auditors. Now, the RAC auditors are CMS contractors, recovery audit contractors that perform reviews of specific issues or areas of interest posed by CMS. On November 5th, 2019, CMS approved and published a new recovery audit contractor focus for renal and peripheral angiography. The description of this review specifically states, in current practice, invasive renal and peripheral angiography is mainly used to clarify inconclusive or contradictory findings of non-invasive studies or used in conjunction with therapeutic procedures. Therefore, diagnostic, aka standalone, renal and peripheral angiography procedures will be denied without documentation of a prior, inconclusive, non-invasive study that supports the medical necessity for the invasive angiography. Additionally, renal and peripheral angiography services will be reviewed for application and observance of correct coding guidelines. This review has been designated by the recovery audit contractors as a complex review, which means complex reviews allow these auditors to request claims data directly from the providers, and they can request this data from as far back as 3 years. So what does this mean? When renal, peripheral, and/or visceral angiography does not include documentation that a prior non-invasive imaging study was performed and inconclusive, any payment may be denied or potentially recouped. Remember, as far back as 3 years. Now, also given the reference within the definition to therapeutic procedures, it would be expected this would apply to all angiographic imaging, to include angiography performed during an intervention or a therapy. This documentation must meet medical necessity according to the guidelines and must include the statement that a prior inconclusive non-invasive study was performed. Therefore, we make the recommendation that this information be included in all angiography performed, whether it's a standalone diagnostic angiography. I most commonly see it performed during intervention, but again, medical necessity, and this is what the recovery audit contractors will be looking for as far back as 3 years. Now, as always, it's best practice to include all clinically relevant prior studies within the dictated report. So that is our final topic today. Some key takeaways from today's discussion that we hope you've all benefited from is go back to maybe your other counterparts, your other interventional radiologists in the group, and have these discussions. Review documentation or templates and your workflow to verify that this type of information is adequately supported in your documentation, and or you're capturing all the charges for the work you're doing, specifically regarding the dosimetry calculations and treatment planning for Y90. Have discussions with your facilities and your billers, again, to ensure you're capturing all of the work for the procedures you're doing. So that will wrap it up for my part of the discussion. So Tara.
I think we can close out the webinar. And I want to thank Stacy and Leslie for their time and expertise. As you can see here, their email addresses are listed. If you have additional questions or you walk away from the webinar with some questions in mind. So thanks everyone who attended, and a big thanks to Stacy and Leslie again.